Um, Evening, everyone. I wish to thank you for coming, those that are in Holden Hall and those that have logged on online. Unfortunately, our guest speaker is had to log online because he's not very well and doesn't wish to spread his germs to us, isn't he nice? So it's over to you, Ahmed.
Thank you. Thank you, Shirley. A very good evening to everyone in person at Holden Hall and everyone that's joined virtually. My profound and deep apologies from the bottom of my heart. I do like to come to Hall and deliver this lecture every year and update you on this topic very close to my heart. But I've been away abroad and I've picked up a nasty bug, which has caused me much bother. I hate it to be transferred to anyone I meet in person. So therefore, regrettably, I am online, but I hope I can make it as informative and impactful as possible, notwithstanding the constraints of my physical absence. The topic today is low blood sugars in type 1 and type 2 diabetes and reducing risk through research, an area where I've spent considerable amount of time both in clinical practice and research. I work as a senior lecturer at the University of Sheffield and a consultant in diabetes in our local university hospital diabetes service. And I also am responsible for training the next generation of diabetes endocrinology researchers. So, in terms of what I hope to do, I should tell you that I also get supported for research and for speaking by the following companies, and that's important for you to disclose. But my talk today is not conflicted by my work with these companies or indeed to these technology manufacturers. I'll tell you about hypos, what has helped recently in dealing with them, and I'm very excited to share hot off the press feedback from some of our patients or people with diabetes using the Omnipod 5 hybrid closed loop system. The risks of hypos, which you'll be aware of, and it can, of course, be very scary, and people with diabetes can talk to this much more than I can as a researcher, but I will give you the clinician's perspective. And finally, I talk about what me and colleagues are doing around the world to reduce the risks to people with diabetes. And finally, I conclude. So, I suppose the first thing I'd like to say is that insulin is a wonderful drug. You see, we measure how effective a drug is by how many people required to be treated by a drug for it to give clinical benefit. This is a concept in medical science known as numbers needed to treat. Now, you'd be surprised, not every single drug will help every single person taking it. So, to give you a broad example, somebody taking an ACE inhibitor, which is a tablet for blood pressure, ordinarily around 20 to 30 people will need to be treated for one to benefit. Take a statin, for example. Well, then with statins, research shows about 20 to 30 people again need to be treated for one to benefit. But insulin stands unique in all of these drugs because it has a numbers needed to treat of one. Every person that is treated with insulin will have a benefit on their blood glucose. Of course, the inadequacy of insulin is that it's given in the wrong place at the wrong time. What do I mean by that? Well, in people without diabetes, after consuming food, insulin is secreted from the pancreas gland directly into a vein draining into the liver, and it's produced rapidly in response to rising sugar levels in the blood. Well, in diabetes, we give insulin not in the vein in the liver, we give it obviously under the skin. And often, many of my uh, patients and people with type 1 and indeed type 2 diabetes find it difficult to time their quick acting insulin relative to the meals. And that in essence, causes an inadequacy of insulin treatment where insulin is relatively mismatched the carbohydrate content of the food people are consuming, leading to this complication of hypoglycemia or low blood sugars. And we define this by two levels, where we think a level of sugar less than 3.9 should alert people that they're going low, that they're low, but they may not have any symptoms at this stage. But certainly, if the sugar levels go below 3 millimoles per liter, well, we know that this can be particularly harmful in terms of consequences for the person with diabetes. Now, what is a severe episode? That's any episode needing help from a third party. So when you're talking about your DVLA declarations, and if someone in healthcare professional wise asks you, have you ever had a severe hypo? Well, that's when you needed help from someone else. And I just like to make a distinction here. Take the case of one of my patients who told me, well, I had a hypo and my husband brought over the Lucozade to me and gave it to me, but I was able to treat or take it myself. Now, in technical terms, they needed help from someone, but they could have, had the need arisen, gone and taken the Lucozade out of the fridge themselves. And therefore, this would not qualify as a severe hypo. On the other hand, a younger person I treat uh, had their alarm going off in the middle of the night. They couldn't wake up. Their mother came in and saw them not looking well, tried to wake them up, couldn't wake them up, called the ambulance, and the paramedics had to come out, put in a drip of glucose, and bring the sugar levels up. That clearly is an example of a severe episode of hypoglycemia. And we know that when it comes to type 1 diabetes, most people on average will have 1 to 2 episodes of severe hypoglycemia, needing help from someone else for treatment per year. And actually, in those with type 2 diabetes treated with insulin, you also have 1 episode roughly every couple of years. But when you match people with type 2 with how long they've had insulin, so say, for example, you have someone with type 2 who's had insulin for 10 years, and you match them with someone who's had type 1 for 10 years and on insulin, then the incidence, the occurrence of hypos is actually fairly similar. Okay. And what causes hypos? Well, I already said to you, we were giving insulin in the wrong place at the wrong time. So we're giving into the skin, it has to find its way into the bloodstream. And often people find it difficult to match insulin to carbohydrates because of they might go to a restaurant and they're not familiar with the content of the food. So they overestimate how much quick acting they need, or they actually have a troubled day at work and they're rushing home, they missed the bus, so they have to walk home, and now the insulin's on board, but they haven't accounted for the exercise and they go low. So it's a mismatch between the amount of glucose or carbohydrates in the blood and the insulin. We know that people who have very long duration diabetes, certainly more than 20 years, that are higher risk. Alcohol and drugs obviously increase the risk, not only because they take away some of the awareness or warning signs of hypos, but alcohol in particular reduces the ability of the liver to release starch, which is broken down into glucose. What I tell my patients with alcohol is, if you're going to go out drinking, and this is mainly younger people, but also people who enjoy a night in the pub a couple of days a week, I say, look, what I'd like you to do is take half the amount of quick-acting insulin you would with the meal before exercise. That's if you're on pens. And I wouldn't cover any alcohol drinks with insulin, so don't cover it. And actually take something carbohydrate rich if you've had a few drinks, because alcohol can actually initially cause sugars to rise, particularly if it contains sugar itself. But later on, as you've had a few, it inhibits the liver releasing glucose, so it can cause hypos, and the effects can last up to a couple of days. We know that in sleep, the risk of hypos goes up because you can't recognize symptoms as well. Physical activity I've covered. And sadly, as people with diabetes grow older, the warning signs and the body's defense mechanisms against hypoglycemia are gradually eroded away, and that increases the risk of hypos too. It goes without saying that if you're trying to aim for very, very tight glucose control, that can increase the risk of hypos. Now, that used to be very much the case with people on pens with type 1, but with the advent of hybrid closed loop therapy, which I'll cover and explain the concept of, we're seeing that we can get very good blood glucose control without increasing the risk of hypoglycemia. And that, if you like, is the holy grail that I, as a diabetes clinician, am aiming for. David, can you still hear and see me clearly? Because I have no feedback from the audience. So I rely upon you as my eyes and ears in the hall.
Okay, we've got some questions for you here, but
Okay, well, we have two options, David, and I'm entirely content. I can answer the questions now, or we can do them at the bottom. At the end, I've got a list of them. Entirely up to you and the audience.
okay, right. Anybody got any questions now?
No.
Nope. Right. Yep. We're okay to go.
David, I'm entirely content for you to interrupt and stop me. And indeed, the same is true for the online audience, should they wish to do so. I'm perfectly fine with that. This is meant for your benefit, and that's why I'm here. Okay. So screening. How do we screen people at risk of severe hypos? Well, I look at their hemoglobin A1C, I look at how long they've had diabetes, I look at their age. Hypos beget hypos. So if someone's had multiple hypos in the past where they've needed help, then the likelihood of this happening again is higher. Impaired awareness of hypoglycemia is when you lose your warning signs against hypos. We know that people on high doses of insulin who are very active and where the kidneys and the liver are not working very well are at higher risk because the kidneys and liver clear away the insulin people have for treatment. So what are the symptoms? Well, everyone with diabetes in the room who's had a hypo will be familiar with this. You'll have trembling and sweating and shaking, but after many years of diabetes, you can lose some of these symptoms. People will start to have difficulty concentrating, confusion and weakness. Some people report nausea and headache. You'll obviously have low glucose, and the key thing is it will respond to treatment with carbohydrate. One of the first times I encountered someone with hypoglycemia was a friend of mine. We played football together in medical school in Newcastle. And I remember him taking insulin after the match as he had a snack. And then we went out, as students do, for a drink down to the Union. When we were playing pool, I recognized that he wasn't being himself. And a man walked past him and brushed him. And my friend then became a little bit upset and angry. He started to sweat. And the bouncers arrived and they took my friend and they pushed him outside. I followed him promptly. When I got outside, I saw him becoming increasingly aggressive towards the bouncers and they were manhandling him. And at that stage, I recognized that something wasn't right. I said to him, "Are you okay?" And he said, "Get my bag, let's check my sugars." And we did, and he was low. It reminded me that the brain can actually become irritable with low sugars. In different people, it presents in different ways. In the case of my friend, he became irritable and exercised. In other people, it can basically lead to confusion. Some people can become tearful, other people can have difficulty speaking. What I'd like to do at this stage, David, is invite if anyone in the audience would like to share their own experience of hypoglycemia, either virtually or in the room. I'd just like to hear from the audience what they think.
Yeah. Hello. But recently, if I get a hypo, my sight goes blurred. And I know it's a hypo because as soon as I take some glucose, it comes back. But it didn't used to do that.
That's really interesting. And I think it highlights the point that hypos are not all hypos are created equal, and how they affect individuals varies. And what might be the hypo symptom for you may not be the case for someone else. The fact that the eyes are getting blurry, again, is something unique and something I haven't really heard before. I've heard people telling me their eyesight gets blurry when the sugar levels are very high, but certainly with the low sugar, this is one of the first times I've heard this. So thank you for sharing it.
Mine goes slow, sort of black and white.
Yes. And that's really interesting too.
Right. Yeah.
Linda Brody has her hand up. Would you like to ask a question, Linda?
I just wanted to comment about hypos, really.
Yes.
I actually lost my memory once as a teenager from repeated hypos week after week. I didn't know who my parents were. I didn't know my brothers. It took about 12 hours to for it to wear itself off, but it was pretty scary.
I can only imagine what that must have felt like, but that's so, it must have been terrifying. How old were you?
13, I think,
Oh.
something like that. Yeah.
That's really interesting. And thank you for sharing that. I just want to emphasize again the point that 3 people have now told us of 3 distinct symptoms of hypos, which the textbook doesn't mention. Memory itself can be lost, but for it to come back is fairly uncommon, Linda. It's normally people who've had many, many, many episodes over many, many, many years that start.
I did have many episodes, and here I am 52 years later, still having hypos on a pump, you know.
Wow. And you see that that just emphasizes to me, Linda, two things. First, that despite many advances in insulin and technology, hypos continue to be a problem.
Yeah.
And two, the inadequacy, despite its brilliance, I should emphasize, the relative inadequacy of insulin as a drug. And I made the point in my introductory slide. Thank you for sharing that. That's really helpful to know, because there are a group of people in my medical and research community who feel that technology is going to completely cure hypoglycemia and it'll be a thing of the past.
I only wish. I really do.
So
Yeah.
do I. But what I argue to my colleagues, and maybe I annoy some of them now, is that the technology is part of the answer. It doesn't take away from the basic facts that I've explained, is that in people with type 1 in particular, insulin is not being given in the right place at the right time. And even with pumps and very fast acting insulins and sensors and pumps that talk to each other, we can but try and control hypoglycemia. We cannot necessarily always abolish it. And I think the other point to make is that we need to work with people with diabetes to equip them with education, which is the reason why I'm here tonight, so they can self-manage their own condition. Thank you. You've reinforced my own beliefs, and I will, if you don't mind, share an anecdote anonymously with colleagues, if that's okay, Linda.
Yeah, sure. Sure. I mean, actually, my insulin sensitivity factor has been rising since menopause. I don't know if you know anything about that.
Happy to comment on that.
Yeah.
As we go through menopause, there are changes in the hormonal balance. There's two distinct phases in life when glucose control is affected. The first is in puberty, when people are going through growth spurts and all hormones that are associated with puberty and growth development go up. And then the other aspect is in menopause in women, where there's a change. So, but that does happen. It should be temporary. Um, and ideally it should settle down. Uh, are you on a closed loop system, Linda, if you don't mind me asking?
Yes, I am.
What system are you on?
I'm on the Tandem T-Slim X2.
Are you looked after in Sheffield?
No, sadly, I live down in Bristol.
Oh, right.
Yeah.
So, well, thank you for joining from all the way down in the southwest.
But you know, I was diagnosed in 1973, and there was no education back then. You know, so it's been a tough slog.
Wow, I can only imagine, but coming to the point about the menopause and that the system should adjust insulin delivery to deal with this. You may need to increase your basal rates as well, particularly in this time. With the Tandem, there's a fixed glucose target, so you can't really change that. So
No.
changing the insulin sensitivity factor seems sensible. Thank you. There's
Yeah.
a question from Holden Hall. Is that right, David?
Yep.
Yeah, I'm happy to take it.
It was just on the theme of memory loss. I was diagnosed with type 1, well, undiagnosed with type 1 during lockdown, and was very ill for almost a year with nobody taking any notice. But I've lost a lot of memory, and it's not returning. I've lost years worth of memory, even down to forgetting when my daughter got married, where she got married, everything. But it's not returned. I was told, because it was a traumatic entrance to hospital when I was finally taken in, that it would come back because it was a traumatic incident. I went in with DKA at 3.9 and other things, but it's not coming back. They told me it would, and it's got worse, really, which is a bit worrying on top of everything else. And quite distressing as well at times, you know, when people mention, I mean, I believe I've been to New York, Madeira, and wherever else, can't remember a thing.
Oh, no.
Nothing at all. So it's just in what the lady was saying, she was lucky as came back. Mine's not coming at all. Sorry, that's me.
Thank you. I didn't catch your name.
It's Jane Fennell.
Jenny.
Jane Fennell.
Jay, thank you
Yeah.
so much for sharing your experience. Again, my empathy with what must have been so terrifying for you and continues to be distressing for you. We know that changes in blood glucose and certain insults to the body can affect memory, you were advised correctly based on what we know that ordinarily it does come back when the sugar levels return to normal. It can take its time. It is concerning that it's not come back for you. Have you seen your general practitioner about the memory loss?
Yes, it's, well, no, not really a GP, no. No, I have mentioned it. It's not recognised really. I think I've got grey hair. I think it goes with it.
Well, not always. It's true what they say is that as we grow older, we do grow wiser, but it doesn't come alone. There are other ailments that afflict us, all of us, including me. But, you know, if the memory loss is not in keeping with certain things, it's worth looking into. Certainly, if I was your physician or consultant, I'd want to make sure that various hormone levels, for example, B12, folate, etc., nutrients were normal, your thyroid function was normal. If you hadn't had any scans, we may want to consider doing a scan of the brain. But of course, I'm not here to give you specific clinical advice, but these are the general principles that I would be looking at if I was your physician, and you may want to discuss that with your own healthcare provider. Thank you for sharing your experience, and I'm sorry that is so distressing for you.
That's all right. I just thought I'd share.
It's really helpful, very helpful indeed. I'll move on, David, if I may, to the treatment of hypoglycemia, which is very much a key slide. The key thing is you would recognize that you're low, you confirm it, either with a continuous glucose monitoring device or with a finger prick, and you treat it with quick-acting carbohydrates, usually 15 grams is sufficient. If you're in a closed loop system where a pump and sensor are talking to each other, ordinarily you're only going to need about half of this. And then we always advise to check it to ensure the sugars are rising above 4 and to retreat. Now, one of the key things is that you take quick-acting carb and then you back it up with long-acting carb to soak up that insulin. What do I mean by long-acting carb? Well, I'll give you another anecdote. When I was a registrar training, I was working with a consultant, and a patient had an episode of hypoglycemia in the clinic room whilst waiting to see us. And I'm sure all of you will be aware of the long waits sometimes we all have to endure, including me when I had a recent appointment in hospital. And at that time, they had just walked up the hill, had their insulin, and that caused a mismatch. And they started to have a hypo. It was recognized, we treated them, but then they walked home without having long-acting carb treatment, and they collapsed outside. So what I mean by long-acting is a piece of toast, you know, a sandwich, something that will keep the sugar levels rising after. Now, this varies from person to person. I'd just like to invite the audience to share their experience of how they would treat hypos and what they find beneficial. If somebody on pens could comment, and if somebody on a pump or a sensor or closed loop system could comment, I think that would be of instructive value. Anybody in Holden Hall or online would like to comment?
I have jelly babies.
Yeah, jelly babies for one.
Anybody else?
Orange juice, carrying with me what time?
Glucose tablets, orange juice.
Vanessa says I use dextrose tablets. Yes. The strength has gone down, which many of you will recognize. When I was a medical student, we used to recommend, and that's true for many other drinks as well. But it's perfectly reasonable to use dextrose tablets, jelly babies, but often a good idea to back it up with long-acting carb, particularly if there's a significant hypoglycemic episode.
What I find is the 15 grams of fast-acting carbs, waiting 15 minutes, my sugar has usually gone further down.
Yeah,
Yes.
So that doesn't sort of work, having 15 grams and waiting 15 minutes. I know they say you should, and it may rise later, but it doesn't rise as fast as you're suggesting on that stream.
I mean, that's really.
Thank you for pointing that out. So, and the reason why I've invited comments is to highlight exactly the point you make, which is that individuals are different and there's person-to-person variation in how their body gets hypoglycemia and how they react to it. I'm going to demonstrate on the next few slides why that is the case, because you see, there are defense mechanisms all of us have which prevent against hypos, because the body needs glucose as a fuel and they're altered. So you should do, as one message from me, what works for you. This is a general slide we use to teach healthcare professionals as to within which time frames we expect different things to happen. So it's a good point that you raise. And we know that CGM has helped for sure, but it has its limitations because it can overread. And what I mean by that is, say that someone is hypo and the sugar level is 2.5 in the blood, and the CGM may still read at 3 or 3.5. Now, the way I get around that is I explain this to my patients, but I also say, why don't we set your alarm at 4.5 or 5 for low blood glucose? And that way they get the alarm in good time before they go low. We know that CGM allows you to look at your trends over 24 hours, look at your lifestyle, and it's comprehensive. The analogy I use is, imagine now, again, an anecdote. When I was growing up in Swansea in South Wales, my parents would give me the A to Z when we had to go to London and had to navigate my way around the North Circular as a young A-level student whilst we were trying to find a relative's house in a distant part of London. And of course, with the A to Z, you look at all the map points and map it out. And what I say is, well, A to Z is, if you like, finger prick testing. There are distinct points in time where you're referring to your glucose, those distinct points on the map. And a CGM is a satellite navigation system. It's telling you in real time the direction where you need to go. It's giving you directions of whether you're on the right course or not, whether the sugar is rising or whether it's falling. And most of all, it gives you alarms. Like a satellite navigation reroutes you, the CGM gives you alarms as to where you need to be. So anyone that's used it will find it has benefits, but also some issues around accuracy, particularly with low sugar levels, or when the sugars are moving fast, for example, after exercise or after meals. We also know that structured education, so in Sheffield we do Daphne, helps. We know that analog insulin pumps, and the artificial pancreas, so-called artificial pancreas, helps. I don't like to use that word because the closed loop systems where the pump and sensor talk to each other don't contain glucagon, which is another key hormone the pancreas makes. Most systems don't contain it. One or two do, but they're not in widespread clinical use in the UK at least. Finally, we can replace people's islet cells or give them whole pancreas transplant, but the drawback with this is that you need to take lifelong immunosuppression, and that in and of itself can increase the risk of various complications, including cancers potentially. So we ordinarily only replace the pancreas if someone's going to be on immunosuppressants for, say, a kidney transplant. We'll replace their pancreas as well at the same time. So these are some of the interventions that have helped. Now, these are some of the closed loop systems. So how does it work? Well, you've got a sensor which every 5 minutes sends a signal to the pump. In this example, in the cartoon, this is an Omnipod 5 hybrid closed loop system. And you carry a controller device, and the controller contains the algorithm, which basically tells the pump how much insulin to give. Now, I'll give you an analogy. Most of you will be familiar with Subway, the American sandwich outlet, eatery. If you go to Subway, you have to make 3 choices. You have to choose your bread, you have to choose your filling, and you have to choose your sauce. The analogy is closed loop systems are similar. You have your bread, that's your continuous glucose monitor. Every hybrid closed loop system has a continuous glucose monitor. You have your filling, which is a pump. You can have different pumps talking to different continuous glucose monitors. And the secret sauce is the algorithm in the system which determines how much insulin to give to keep your sugar levels on an even keel. I hope that makes sense. This analogy was taught to me by my colleague and friend, Professor Pratik Chowdhury in Leicester, but it really encapsulates in a simple way, I hope, the concept of closed loop. And you've got different systems available on the slide. So Linda shared with us that she uses the Tandem system. That's the one over here. There's a Medtronic system. There's also the Insulet Omnipod 5, which I've demonstrated. The CAM APS is a system that's produced in the United Kingdom by research at the University of Cambridge. You've got Medtronic 780G, that's their latest system, and the Diabloop, which is, well, something we don't really use too much in the UK, but is available in the United States. So those are some of the systems that we have. Now, my patients really do find this helpful. I asked a group of patients using Omnipod 5 before I came to this talk what they felt of it. I'd just like to give a minute for you to read these slides, comments. So, David,
Yep,
are we having some discussions in the room?
no, I think it was a new joiner.
Oh, okay. Okay, that's fine. So the key point when I look after people with a closed loop in general and OP5 in specific is when I ask them how it's been for them. I've done a clinic today, as I mentioned. Every single patient that I put on it said to me, oh, it was life-changing, it was amazing, it was very helpful. That's a positive impact, but it's not all positive. Some patients tell me, well, it's good, but it's not a cure of type 1, and I still need to interact with it. And I find it difficult to trust the system after having been on pens for so long and having managed my own condition so well. And that the alarms can be particularly annoying, and that the system can sometimes fail. So these are all things which are important to bear in mind. Just looking at the chat where CGM delay is annoying, and that's the point I've made. I hope, Linda, and thank you for raising that. Linda, you say that you lost your hyper awareness on a Medtronic Guardian and you bend it and got awareness back after 3 weeks working on feelings. These have been discontinued. When you say feelings, do you mean recognizing the symptoms of hypo and dealing with it in a sooner or more
Yeah.
effective fashion?
Yeah, basically.
That is really, really fascinating because we know that there's a program in the United States called Blood Glucose Awareness Training, which focuses exactly on that. It focuses on training people to recognize the symptoms and cues of a hypo and treating it effectively and quickly. So that's really interesting you mentioned that.
Mm.
Vanessa, you've raised a question, which is, when are you eligible for a pump? Okay. I'm just going to spend a minute on this, David, because I think this is absolutely crucial. NICE in the UK have, or in England, I should say, because it doesn't necessarily cover Scotland, in England, have produced guidance around who is eligible, and these are widely available. How we apply that in a local construct is important because the vision is that most people with type 1 diabetes should be in a hybrid closed loop system, pump and sensor talking to each other. And there's a 5-year plan to do this. So the idea locally is to do it in a way where we have waves of onboarding people and you start with where need is greatest. And in our local context, at least in Sheffield, that is people who have complications of diabetes and who have a high A1C above 69 millimoles per mole, those who are pregnant or planning to become pregnant, and younger people between the ages of 18 to 25, certainly below the age of 18, because they also stand to benefit quite significantly in total. My short answer to you is that, plus if you have what we call problematic hypos, in other words, the hypoglycemia burden is such that you're having difficulties in day-to-day living, you're having episodes of severe hypoglycemia, you've lost your awareness of hypoglycemia, then you should discuss it with your healthcare provider. As a general rule, in my own practice, I try and move heaven and earth to get people on a pump if it is the right thing for them. But not everybody is going to benefit from a pump. And in certain people, actually, a pump can be a backward step as well. So having these discussions is very, very important. Needless to say that pump therapy is only really sanctioned for type 1 diabetes in the UK. There are clinical trials that it will become increasingly popular in those with type 2, especially those who are on insulin in due course, but we're not there yet. I hope that answers your question, Vanessa. If not, please let me know.
Yes, thank you. That's great.
Pleasure.
Thank you.
Pleasure. Okay, so what are the risks of hypos? Well, this is a scary bit. I'm not here to scare you, but rather share these slides from a place where if I can empower you, we can avoid the hypos and you can talk to them, talk to healthcare professionals, that is, with this knowledge about the risks so you can come to informed decisions. We know that if your sugars go low, your brain doesn't work very well. We've had examples on the call for people having difficulty with memory. I gave you the example of my friend all those years ago in Newcastle in the Students' Union becoming angry. We know that you can actually have seizures and coma if it happens. Some people become tearful, and that's particularly the case in young children or very young children where their behavior may change, and mum or mummy will know because, Amelia is not being herself and she's hypo. We know that hypos can increase the risk of heart attacks because it can cause the blood to become stickier and also cause inflammation. And I've done work in that field with my PhD thesis focusing on that. We know that hypos can also increase the risk of fractures because, well, if you have a hypo and you fall, then you're likely to have a fracture essentially. But more than this, hypos affect you not only on the day, but the day after. If you're awake all night with a hypo and your alarm is going off on the sensor and you have to go to work the following day, you're not going to be feeling 100%. Your partner or your pet or a significant other or your children are potentially going to be affected. Your work's not going to be that great. It's going to have an impact on you and your family and significant others. It also has an impact on society as a whole because people with diabetes, when they have hypoglycemia, are not as productive, understandably, as they normally are, and that leads to loss of productivity at a national level. If you end up in hospital with hypoglycemia, of course, that has implications for the healthcare system. All in all, hypoglycemia is an unwelcome complication of insulin treatment. Right. This is absolutely key because this explains why some people hypos can be treated and their sugar levels rise within 5 or 10 minutes, and others, well, if they wait 15 minutes, they're going to end up on the floor. In people without diabetes, we have certain lines of defense that prevent people without diabetes from becoming hypo. When the sugar levels hit 4.5, insulin produced by the pancreas is switched off. First line of defense. When it goes down to 3.8, the body starts to make two hormones, glucagon made by the pancreas, by alpha cells, which are in the pancreas, and adrenaline made by the adrenal glands, two small glands that sit on top of the kidneys. And what they do is that they essentially bring up your sugar levels. Adrenaline also gives you the symptoms of trembling, shaking, sweating, and they tell you that you're low. If you go below that level, your brain starts to be affected and you start to lose a bit of memory potentially. You start to become a bit confused. You can't do tasks as well, and that's known as neuroglycopenia. Doctors speak for low sugar affecting the brain. And finally, if the sugar levels go below 2, there's a risk of seizures and coma, and anybody who's had that or seen that will recognize that. Now, in type 1 diabetes, you lose your first line of defense because you're not making insulin anymore. After many years, with repeated episodes of hypoglycemia, you also start to lose your adrenaline response. And that means that your hypos become deeper, they last longer, but also because adrenaline gives you the symptoms of hypo, so-called hypo awareness, you also start to lose some of that, which means that you could potentially have the effects of hypos on the brain before you've had a chance to treat it. And that essentially is how you end up having severe hypoglycemia. Glucagon is also very, very good at protecting against hypos, but sadly it's also lost within most people with type 1 diabetes within 5 years. Now, the good news is, if you can avoid hypoglycemia, and Linda mentioned this meticulously and very, very carefully, you can get some of this awareness back in some, but not all people. And that is basically the fundamentals of how we treat impaired awareness. We avoid hypoglycemia as best as possible by educating the person with diabetes and giving them technology that prevents hypos from happening, with the hope that we can restore their adrenaline response and therefore their symptom response, so that when they do become hypo, they get symptoms and they can self-treat before they get low glucose effects on the brain, which means that they end up on the floor or they need help from a third party. I mean, I like this slide because I'm a football fan, but it's kind of a scary slide. I mean, this looks at the incidence of heart attacks in a borough of Munich over several years, and it shows that in 2006, when Germany hosted the World Cup, Germany were playing Argentina quarterfinal match, that in that particular area of Munich, heart attacks shot up the roof. Now that kind of tells you, well, adrenaline or watching Germany play Argentina is not a good thing, or adrenaline is not a very good thing for the heart. And of course, what's common between a very good football match and a nasty hypo is adrenaline. And that gave me the initial idea all those years ago around trying to understand why and how hypos were causing cardiac problems. And what we came up with is that low sugars can make your heart go into funny rhythm, and we showed that in people. It can make your heart beat faster, and if the artery supplying the heart, the coronary artery, is already furred up, then it's a supply and demand thing. Well, the heart's pumping faster, so it needs more blood, and if it needs more blood, it needs to get it quickly, and if it doesn't get it quickly, then there's a risk of the heart muscle dying. We call that ischemia. I also showed in my own research that low sugars make your blood thicker. It causes the platelets, which prevent blood from leaking out of your vessel when you're cut, stick together, and it also causes inflammation. If I was chased by a saber-toothed tiger or a giant mammoth, my body would release adrenaline as part of what is known as a fight or flight response, because it recognizes that I'm in a compromised state. Similarly, when the body is experiencing hypoglycemia, it enters this fight or flight response. That makes sense why all of this happens. Your heart beats faster because it wants you to run or to do something. Your blood starts to become more clottable because it recognizes an insult. It doesn't it thinks that you might be attacked, but it's actually a tiger's not going to attack you. It's rather the hypoglycemia exerting its effect. So the mechanism is the fight or flight response and the adrenaline. But in this scenario, it can actually be harmful. I hope that makes sense. Okay. Having a few nods, which is always reassuring as a speaker. So I'll just move forward. So I've explained to you what is hypoglycemia. I've shown you why it occurs. I've explained the risk factors for it. I've talked about how you treat it. I've explained the physiology of the lines of defense. I've shown you what closed loop systems are and how they work. I've explained how many people find benefit, but how technology can be annoying. I've also explained how hypos can cause problems on the brain and the heart. Now, the question is, what are we doing about reducing these risks? Well, I always mention this study, which is still ongoing, and if you are interested, please do reach out to me. It's called the Best in Type 2 study, where we're looking at if people with type 2 diabetes who have low blood sugars can be protected against some of the inflammation by giving them commonly used blood thinners, such as aspirin. The idea is that if hypos cause inflammation, then if we can give people a blood thinner, such as aspirin, then we might be able to reduce some of that inflammation. And in this study, we're looking at people who have type 2 diabetes, who've not been on insulin for more than a year, or between the ages of 18 and 65. And we want to make sure that they haven't had any heart disease or any heart attacks prior to coming into the study. And we give them a Dexcom G6 sensor to allow them to monitor their glucose as well for 2 weeks. And on one single day, we randomize them, in other words, divide them randomly into 3 groups. Either they receive no drug, or they receive two different kinds of blood thinners. One group receives one kind, another group another. And then we bring them into our clinical research facility at the Northern General, where we artificially lower the blood glucose in a very controlled fashion. And we're comparing how the different groups perform in terms of inflammation and clotting of the blood when the blood sugar is lowered in that day. So do take note of this. You're welcome to take a screenshot, and you can essentially have a look at it if you like. At this stage, Lindsay's asked me, Dr. Iqbal, what's your friend from Newcastle doing? Hope all's good and his type 2 isn't too interesting. So Lindsay, he's doing very well. The last I heard, he was training as a junior doctor, but that was 17 years ago. I haven't been in touch with him. He was very bright, and I'm sure he's doing well. It was a long-standing type 1. He was a footballer, and we had a good time playing football. Linda, you ask, can thousands of hypos cause adrenal insufficiency? Well, that's a wonderful question to ask. It can cause, Linda, a reduction in your adrenaline response to hypos. Thousands of hypos will mean that your body will not make adrenaline when you're exposed to a hypo. But if I put somebody who had 1,000 hypos on a treadmill, and you'd be surprised, but these studies were done, or they had a cold water immersion bath, they would still make adrenaline. Which tells you that the problem is not the adrenal gland itself. The adrenal gland can still make adrenaline. It's just that it cannot make adrenaline in response to hypoglycemia. So why is that the case? Well, you see, what happens is when sugar levels fall low, there is a part of our brain that senses the sugar levels falling. It's known as a glucostat. If you like, a central barometer of glucose. And the glucostat then fires off through nerves to the adrenal glands to tell it to make adrenaline so that the sugar levels can rise. When you have many, many hundreds and thousands of episodes of hypoglycemia, the glucostat only fires off those nerves at lower and lower and lower glucose levels, or not at all. And which is why people who've had these thousands of episodes, when you get them to have another reason to make adrenaline, they do make it. So the glands are working. It's just that they're not working because the glucostat is not firing off. The problem itself, therefore, when it comes to hypoglycemia awareness, is in the brain. Lindsay, go back 2 slides. Okay, why? Let me just go back. This one? This one, Lindsay? Can you hear me? Or this one? Okay. I can't hear Lindsay back. Does that answer your question, Linda?
Yeah, I think so. I think I've just become superhuman actually at owning my hypos, you know, because I've been down to 1.3 and been fully functioning. So,
That's great. And I'm pleased, but
and I still sense them and I still have an adrenal response, definitely.
good.
So maybe I'm just strange.
Well, that's really interesting. You see, you mentioned that because some people, despite, and you mentioned you were diagnosed in the 70s, despite long duration type 1 diabetes, can still have some awareness. And this is where I think some people are secreting small amounts of insulin. I'm not necessarily saying that's the case in you, Linda, but generally, I think some people also secrete small amounts of glucagon. What that means is, if I go back to my lines of defense slide, they can still switch off that small amount of insulin that they're making, still produce that small, very small amount of glucagon, and that's what protects them. And you'll find that people who have this are also less likely to get complications. And you'll find on social media people posting their pictures of CGM where it's like a flat line. Well, I can tell you, being a diabetes physician for many, many years, that's very hard to achieve.
Yeah.
Some of those people, in my opinion, are secreting small amounts of insulin, and that is protected against hypos. If it's the case with you, I'm very pleased, and I hope it stays that way. In other people, it cannot happen because they've lost their lines of defense. But thank you for sharing your experience. It's very helpful.
Yeah, I think keeping fit's part of the issue, you know. being healthy and exercising every day.
Yeah, exercise is interesting. Exercise can help because it can sometimes augment, it can boost up your adrenaline response, and it may be able to help against impaired awareness in particular, but the evidence is mixed.
Mm,
Of course, exercise in and of itself can significantly increase the risk of hypoglycemia as well, can't it?
yeah.
Especially,
I totally do not use the activity setting on the tandem pump because it sends me hypo every time I go and
yeah,
exercise.
that's very interesting. Do you take the pump off altogether?
No, I just use another profile.
Okay.
That seems to work better for me.
That's good. And that profile is very,
Very
very,
low.
very, yeah. So very low amounts of insulin.
Yeah, it's the
How,
only way.
how much percentage reduction is that from your normal profile? Is it about 50% or 60%?
It's 30%.
50% less. Okay. So thank you. That's really important. And it goes to show that the exercise mode can be very aggressive in some people, and you need to go lower.
Definitely,
You need to come up
definitely, without doubt.
with a bespoke profile.
I mean, I think it very much depends on your insulin sensitivity factor as well. You know, I'm very sensitive to insulin now.
Yeah, no, definitely.
Yeah.
A couple of comments. I'm just going to move on. I once had a hypo these days where someone made a cup of tea and gave it, and then they saw the bag was still in it. I did a test and it was 1.9. Yeah. That kind of shows really, Lindsay, how you can really fall on the floor very, very quickly in that time. And it must have been so scary. Does weight influence your hypos? Weight doesn't influence hypos directly in that if you are overweight, you're not going to have more hypos. If you're underweight, well, let me think about this. It can do because if you're overweight, you might be on higher doses of insulin, which may increase the risk of hypoglycemia as we give more and more insulin to overcome resistance to insulin. But weight in relation to the dosing of insulin can increase the risk of hypos, but weight itself, I do not think influences your hypoglycemia risk. The exception would be some very, 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 very low weight people who might be at a higher risk of hypos because they're very, very sensitive to insulin. When you're using pens, how do we really avoid hypos when active? Well, it's with difficulty is the answer, Lindsay. And thank you for asking it. The rule of thumb is if you're doing exercise, Daphne principles, take half the normal amount of quick acting you have with a meal before exercise and half the quick acting dose you would have with a meal after exercise, and consider reducing your dose of basal insulin like Tresiba by a couple of units. But as Linda has just pointed out, even with a closed loop system and the activity feature, she has to come up with a bespoke profile to reduce her risk of hypos. And therefore, the advice I gave is stock advice we think works, but it really is hard. And people who exercise very, very much in an ideal world would be on pumps. If I could afford to put people, everybody would be on a pump if they wanted it. But certainly, in my view, the Ahmed Iqbal worldview, which is divorced from finances and nice and central government and budgets. If somebody wanted, it was exercising, I would say, well, you need to be on a pump as part of a closed loop system so that we can reduce your hypo risk. I hope that answers the question, Lindsay.
Would you tell us please how much pumps are if someone wanted to buy one?
That's really interesting. Thank you for asking. So, who asked that question, just so I can respond?
Jose.
Sorry?
Jose.
Hi, Jed. So, as a general rule of thumb, the cost to the NHS is in the order of £4,500 per year. The principal cost is actually of the sensor, which can cost between 150 to £200 per month. Most diabetes centers will be willing to offer you the pump if you're willing to self-fund the sensor. And certainly we've had cases in Sheffield where we've done that, but increasingly I've been moving people who are self-funding to NHS funding. I think if you're genuinely desirous of a pump, you should seek to speak to a healthcare professional. As I mentioned, there's a whole list of reasons why people can go on a pump. If not now, then in future waves. But if it's absolutely must, then self-funding a sensor can allow you to get a pump from most centers.
Thank you.
Pleasure. Okay, well, the other thing I wanted to mention is the CLEAR study that we're doing. This is a study which is funded by the NIH in the United States, and As you will know, the United States, I think it's fair to say, is going through a tumultuous time. And with the new government, we weren't sure if they were going to continue funding our study, but I've just received confirmation today that, in fact, the NIH will be funding the study. They have cut funding to many, many studies in light of the new administration's views. But thankfully, we've avoided that, and I'm very, very pleased because this study, I think, is going to be absolutely crucial for people with impaired awareness. It's due to start very soon now, in the next 4 weeks. And what we're looking at is people with type 1 diabetes who've lost their awareness of hypoglycemia. And we're taking people and inviting them to partake if they've never had closed loop or if they continue to have problems with impaired awareness despite being on closed loop. For those never been on closed loop, we're going to give them closed loop and also randomize them to education. And we're going to compare whether education in terms of recognizing the cues of when you're low is better than being on a closed loop system. And those that are already in a closed loop, we're going to offer them education to see if giving people education and talking to them about principles of how to use the system and recognizing hypos can actually help them get the most out of their closed loop and reduce their hypoglycemia to improve their awareness. The study does involve having a blood glucose study where we artificially lower the glucose by giving drips of insulin and glucose in a controlled environment. That happens at baseline when you enter the study to see how much adrenaline you make in response to hypo. And then we measure the same after giving you the trial interventions at year 1, and then again another year later. And there is appropriate remuneration for your time and effort. So anybody interested in this study who thinks, well, actually, I have impaired awareness and I have type 1, and I'd very much like to go on a closed loop, but I'm not eligible on the NHS yet, for example, or I haven't discussed it with my local team, I should be eligible, then this may be a way for you to get hold of the technology to continue on it with the likelihood that you'll stay on it when the treatment period for the trial ends. We will be advertising this shortly, and Lindsay, I'll be in touch with you closer to the time to hopefully advertise it through appropriate UK channels locally. Okay, well, I'm coming to my conclusion now. I've spoken and I've really enjoyed our interaction, but I think it's fair to say we've made huge progress against treating hypoglycemia, but we're still way off. We are nowhere near curing it, and I've explained many, many reasons why. They're still problematic. Technology and education can help, but it's not completely the solution. The technology, in many ways, is only as useful as the education and knowledge the person has when they're using it. We're trying to limit the effects of hypos on the heart, and the best in type 2 diabetes study is something very exciting because aspirin and prasugrel, the two antiplatelets, are widely available. They're cheap. We can repurpose them for this purpose. And we're trying to come up with new ways, hopefully through the CLEAR study, to treat and reverse impaired awareness of hypoglycemia. So I'm going to stop there. There's a couple of questions in the chat. Vanessa, when you're ill with a virus and you follow sick day rules, are you more likely to get a hypo? Actually, no, because when you are sick, your body makes hormones like adrenaline and cortisol and growth hormone that pushes sugar levels up, which is why you end up taking sick day rules, because you end up needing more insulin, not less, because again, the body recognizes that it's in a state of stress. Of course, if you take shed loads more insulin and you're not eating at all, then there is a slightly higher risk of hypoglycemia, and you should watch out for that as you go through sick day journey. Ian, you ask Novorapid and Lantus. Sometimes Novorapid works quite quickly and I can have a hypo. Other times it can take 60 minutes. I have been diabetic for 65 years. Can I become sensitive to my insulin? The answer, Ian, is a complex one, I'm afraid. Yes, possibly. When it takes 60 minutes, I'd ask, are you rotating your insulin injection sites? Because that's the most important thing.
I'm sorry, I missed that.
Are you rotating your sites where you inject your insulin?
Yes.
Okay. It's a bit odd that it can be so variable in you, but it's possible for you to increase your sensitivity to insulin by exercise, essentially. That's going to be the key way for you to be able to have increased sensitivity. Linda shared with us how her sensitivity is dependent on exercise, and I think yours, again, it varies person to person, but I think exercise is the key there. and controlling weight as much as possible. It must be very annoying where it works quickly one day and not the other. The unpredictability of it must be very annoying for you.
That's the problem, yes. It's very unpredictable.
Are you on a continuous glucose monitor?
Yes.
Okay. And is it a Libre device?
Pardon?
Is it a Libre device?
No, it's the Dexcom One Plus.
Okay, that's a good system to have. Yes, if I was your physician, I would recommend gentle exercise, 30 minutes at least 5 times per week, and rotation of insulin injection sites and seeing if that helps. Sometimes moving to something called Fiasp, which is an ultra quick acting insulin, can also help when Novorapid is not doing the trick. Have you considered that or discussed that with your physician?
Unfortunately, I don't know whether I should say this, but I haven't actually seen a consultant for at least 6 years.
Are you a Sheffield patient?
But I'm in the Northwest.
Okay. Well, what I would say is this, is that every person with type 1 diabetes should be in a secondary care hospital being looked after by a consultant or appropriate healthcare professional, and should be seen at a minimum frequency of a year for their annual review processes. So you can quote me if you
Yeah, which does as well.
what's that, sorry?
Quote Sheffield Diabetes UK as well to say, yes, we
There you
recommend.
go. You've got endorsement from heavier endorsement from Sheffield Diabetes UK compared to my voice. And I wish you all the best, but you do need to see your consultant, okay? Because these are exactly the conversations that can be had in the consultation. And if not the consultant, another way might be a helpful diabetes specialist nurse, for example. I wish you all the best with that, sir.
Thank you.
Thank you, Lindsay. The HARP-DOC course is a key part of the CLEAR study. And I'm so pleased that it helps you get your symptoms back. And we're going to be using HARP-DOC as part of CLEAR. So in people who have lost awareness, and Ian, if you have lost your awareness of hypo, someone like you may be eligible as well to enter our trial. We are recruiting from across the north of England. We're recruiting from Manchester, from Liverpool, from Newcastle, and from Leeds. We'll have to obviously go through the eligibility very carefully, because also the trial does involve having your blood sugars lowered artificially with drips for one whole day visit. And that experiment is not, it's not without its labor, both on the person and on the team. It is complex, but it's a very accurate way for us to determine how your body is reacting to the hypo and how much adrenaline you're making in a very controlled and safe fashion. There's a question from Holden Hall.
Brenda. Question going back to what you were saying about when you get a hypo, if it's still not gone up to 4 and it goes down, as other people said, you take some more. And then you said take a low acting.
Long acting.
Low acting carb. When you slow acting carb. When you take the slow acting carb, 2 things. One is should you then take insulin for that slow acting carb? And secondly, in a more general thing, would you still take the slow acting carb if you're using a Libre and you're using the insulin on board facility and it says you've got no insulin on board?
Well, you wouldn't take insulin for the long acting carb, Brenda, because you're treating the hypoglycemia. That's the reason for using the long acting carb.
You're saying you've gone up to above 4.
Yes, but
you were saying that take the slow acting carb for any insulin you've got on board, basically.
Correct.
Right?
You're using the long acting carb for insulin on board, precisely.
So if my Libre tells me I haven't got any insulin on board and I know I haven't had an injection for 4 hours, say, is there still any need to take the? Because what I'm finding,
I understand what you mean. Yes, if there is no insulin on board and your quick acting carb solves the issue and your sugars have stabilized, then that's fine. That should be okay. But in most people, hypoglycemia does mean that there's insulin on board. And in that case, you should take long-acting carb and you shouldn't take insulin with it. That's hope that answers your question, Brenda. Thank you. Moving on to the questions, there's a number of questions. I'll try and be brief with each one of them to do justice to them. How do you stop yourself from overcompensating and going hyper? Very, very important question. It comes back to how much treatment you give. Normally 15 grams is sufficient. On a closed loop system, you'll need less because the insulin pump will suspend insulin to prevent you from going low. And the discussion Brenda and I have just had, where if you can work out whether there's insulin on board or not, and use that to determine whether you need long-acting carb or not, well, that will also prevent you going hyper. For example, in the scenario Brenda mentioned, if there's no insulin on board, you've treated the hypo with some jelly babies, it's come up to 4.8, and now you take a sandwich, then you're likely to go hyper. But on the other hand, you've treated the hypo with jelly babies, there's about 5 units of insulin on board, you then need to take the sandwich to prevent you from going back low when the quick acting wears off. How do I stop prolonged hypo after exercise? Okay, well, maybe, I don't know if Linda, you asked this question, but you certainly answered it, is you can use the exercise mode, and if that doesn't work, you can use a bespoke feature in the tandem pump where you can knock off 30 to 50% basal insulin. Some people take off the pump for exercise. I don't recommend that ordinarily. A better way of doing it is to take on carbohydrates before you exercise. You can run your sugars a little bit higher. That is perfectly appropriate. Why do you get what does it say here? Sorry. Why do you get headaches? Well, we discussed that the brain needs low sugar. Brain needs sugar to function, and the low sugar can cause a whole manner of neurological effects. And that's why headaches is a key feature of it. It's a warning sign. Lindsay, you raised a very important point in the chat, and that also, Brenda, comes back to the issue around insulin on board. Your Libre device will tell you about the quick acting, but if you're using connected or smart pens, it should also tell you about the basal insulin. Now, the basal insulin can cause hypoglycemia, of course, but it's not always the chief reason. It's often the mismatch between the quick acting and the carb that's the problem. If you wake up with hypoglycemia early morning fasting, then that usually implies that the basal insulin dose is too high. In that scenario, if you've not had breakfast, you're fasting, you're low, it's worth treating it and then following up with long-acting carb because there's the basal insulin on board. Is keeping your blood glucose high for a while and avoiding all and any lows the only way to keep your hypo awareness back? Well, the answer to that is actually no. The way to get hypo unawareness back is the scrupulous, meticulous, careful avoidance of hypos, but not necessarily by running hyper. And that is where we are hoping to use closed loop and also those educational interventions to allow people to recognize their awareness symptoms, hopefully with a chance of getting their awareness back. We hope to test that in the trial. And the final question is really a comment, which is I've had type 1 for a very long time, and you struggle with the hypos and their effects. And I'm sorry to learn this, but also thank you for sharing it because it motivates me as a hypoglycemia researcher to continue doing the work. And to come back to the earlier point, it also gives me ammunition to use where people in the field feel that hypos are no longer an issue or unlikely to be an issue in 10 years and that we've cured them with technology. It recognizes the fact that with long duration type 1 hypoglycemia can still be frightening, can still have consequences. Thank you. Lindsay, I think these were all the questions that I had. If I've missed any questions or there were new questions since these were sent to me, I apologize. If those individuals are on the call either in person or virtually, I'll be happy to answer their question now.
I've got a chocolate question.
Go ahead.
How do you recommend we manage eating chocolates? I think lots of us want to know the expert opinion.
Well, I would consider myself a specialist in diabetes. For expertise in chocolate, I've asked my wife. She loves chocolate, although she hasn't got diabetes. Well, My view is a pragmatic one. People with type 1 and type 2 diabetes should be allowed to enjoy their life like every single other person and take things in moderation, including chocolate. Chocolate is unique in that it contains a mixture of carbohydrate and fat, so it can have unique impacts on blood glucose. Um, if you can work out the carb content and appropriately dose insulin to it using the Daphne principles, you should take chocolate in moderation, particularly dark chocolate can be very helpful. For people who are on pumps, again, the same holds true. The key, of course, is to pre-meal bolus and to know what you're dealing with in terms of carbohydrate content. Linda says, it's Easter, have a cream egg for your next hypo. Well, yes, that's interesting, and I endorse that. You can say that if indeed it works for you. Chocolate generally, though, is not a fantastic treatment for hypoglycemia because the fat content is a bit higher than the carb content, and it's the quick-acting carbs that you want getting in to get the glucose to the brain to prevent you from falling down. But that's a good suggestion. Thank you for raising it. There was another question about someone feeling dreadful after accidentally giving their basal dose twice one morning. So sadly, that can happen. And the way around that, Lindsay, of course, is by having connected pens which show up on your Libra, whether you have or haven't had your dose. And that can remind you. If there are people on the call who are on pens, I urge you to get in touch with your teams to go on connected pens or smart pens. This can record the dose of insulin you've had, either on the Libre, but also on an electronic indicator on the pen cap. So you can see whether you've had the insulin or not and how much you've had. And this becomes particularly important in people who have memory issues as we grow older or following hypoglycemia, or the case of the lady who mentioned she's had memory issues following new diagnosis in COVID. This is a good way to get around that.
Okay, Alison's got a question.
Can I just ask, please, because obviously this is all about hypo, but over the years, I've probably run my sugars a little bit high because of not wanting to be hypo, but then been told that the most likely cause of me having the heart disease that I've got and having to have stents and a heart bypass is probably because of my sugars being too high. So when we're trying to eliminate hypos, if you like, as best we can, and potentially then just pushed it a bit too high, and now ended up in this situation, would that put you any higher up for getting a pump if you wanted one? Because I've been told it doesn't.
So Alison, I'm sorry you had that bypass and that must have been quite scary for you. You want to be able to run your sugars in the normal range. You don't want to run low because that's bad for you. And certainly you don't want to run high because that is also very bad for you. There's very clear evidence that running high sugars increases the risk of heart attacks and strokes and kidney damage and nerve damage and so forth. So whilst hypos are bad, and that's been the focus of my talk, hyper is also bad. And my aim is to achieve normal or near normal glucose control without exposing people to either hyper or hypoglycemia. Coming to the question about pump, it's on a case-by-case basis, and certainly if somebody has complications which are established or getting worse, then they can be evaluated. As I mentioned, each locality will have their own criteria as to how they implement the NHS England hybrid closed loop plan. It's meant to happen over 5 years, and different people will be included in different waves. Are you treated locally or are you out of area?
Yes, I'm Sheffield based, yeah.
Are you
But I just said to them, unfortunately, when I was told I wasn't high up the list, I said, well, that's probably because I'll be dead before that 5 years comes around.
Sorry to learn that. I mean, my view.
Yeah, that's what, but I'm just saying, I think that, they probably think, oh, she'll not need one.
Well, obviously I can't speak to that. As a member of the service, when I represent the department now, when I say this, our view is that we should get the pump in every person that stands to benefit from it. We work on a principle of clinical priority and the ethical principle of justice, and also within the constraints of what NICE and the ICB tell us to do. age is not a factor. I had someone I
I
started
was
somebody
asked
on,
if I could have one, and I was still told no.
right, okay. I don't know who you had the discussions with, obviously, and it would be inappropriate for me to comment.
Yeah, I get that.
But
Maybe I'll just try again, yeah.
it's always worth a try, but it depends on the local priority in
Yeah,
terms of the local criteria.
yeah,
And if you're desirous of it at your next appointment, you can raise it. It may elicit a similar response, but obviously without looking through everything in the case, I can't comment. But as a general rule of thumb, I hope I've explained the scenarios.
yeah, that's,
I wish you all the best, Alison. And
thank you.
thank you.
I
For,
just got one
sorry?
more. Is
Yes.
it all right?
Yes.
It was just the lady who mentioned about the cost of the HCL.
Yes.
I've seen a consultant twice for about I'm under Doncaster Royal Infirmary, and we've offered to buy the HCL to put the fund, but because no nurses at Doncaster are trained, and you need the help, you need the support of nurses, a team behind you.
Yes.
They're trained, none of the, we've been told anyway, that nobody's there to support you. So it doesn't matter even if you want to put the 4,000 in, you need the NHL's help to
You do.
to learn how to use it as well.
Yeah.
So it's a real catch-22 that, and the other thing is as well, if they look at your time in range and they think you're doing too well, then that's it. You just totally.
Don't get one.
I've had some people say that because they feel resentment about that, thinking about actually running themselves down to range and their HbA1c just to get to the, I think it's 58 in the guidelines, which is really unhealthy. But it shows that people are wanting the HCL and the funding isn't there, is it really?
Exactly.
Yeah.
You raised some very good points. I don't have a solution to any of that.
No, I'm sorry, just linked to what you'd said, even when you approach your endocrinologist.
Yes, I was coming from a place, thank you for raising it.
Yeah.
Coming from a place of our service here in Sheffield, if somebody said to me I wanted it, I'd give them the option of self-funding the sensor, try to provide them with a pump, and we have access to expert nurses to be able to do it. In your scenario, you mentioned that you're from a neighboring peripheral hospital where there is no nurse capacity to do so. Even if you were to self-fund and self-finance, you wouldn't be able to do so. And this again highlights the unfortunate nature of the postcode lottery, doesn't it?
Yes, it does.
And I'm sorry, and this is where the whole idea of the ICB is to be able to level up care. This we are trying to work towards that, in that we're trying to use a hub and spoke model where we try and consolidate HCL use in Sheffield and then use our expertise to train up colleagues in the locality. From my own experience, though, as being a researcher, the place where I'm going to go first to recruit for the NIH CLEAR study is the peripheral hospitals, because I know there'll be people there with impaired awareness who may not have had the opportunity to go on a pump or a closed loop system precisely for the reasons that you've mentioned. And therefore, I'm hoping that will allow me to do two things. One, to offer the technology to people who need to be on it now, and two, take some of the burden off the person living with the condition and bring them into our care, get them all sorted out, and hopefully by the time the trial's over in 3 to 4 years, systems and services in Doncaster, Bassetlaw, in Barnsley and other localities would have caught up. You also raise a very important point about people wanting to run their sugars high and actually artificially breaching the target so they become eligible, because I mean that's just so sad and worrying for me, because even that short period of time of high sugars could have complications. You must remember, of course, that we have this concept of glycemic memory. The body remembers the blood sugar levels, which is why when I see young people, they tell me, yeah, they're not too bothered, or they're happy to run the sugars high because in youth they feel that they'll be okay. But the body remembers even short, brief periods of high sugars, and there's that higher risk. So I would completely advise people not to do that, and rather to advocate for themselves and to make clear and cogent cases with their healthcare professionals as to why they feel they could benefit from the technology. Certainly, when people have done that with me, I've always gone off from a position of trying to help and trying to create solutions within the constraints that we have. Thank you for raising your points, very valid. And my heart goes out to everybody who wants to be on this technology and isn't on it. Lindsay says that Lindsay, will DUK be able to help Alison in this regard to advocate for her?
Yeah, I think we can have a chat with Alison and look at writing a formal letter on her behalf or with her.
Yeah.
I think.
Obviously, Alison, if that works for you, we
Yeah,
don't
yeah.
we don't want to shoehorn you into anything on an open forum.
No,
But
I can speak with Lindsay first, yeah.
what's that? Sorry.
I can have a chat with Lindsay first.
Yeah, of course. I think, but I do feel for you, and I wish you all the very best.
Thank you.
Pleasure. There's a couple more questions before I must excuse myself, Lindsay. There's two questions. What are the long-term effects of so many hypos in your brain body? I think we've covered that in the talk, that there's an increased risk of cognitive impairment, there's increased risk of heart attacks. And many people find their hypos induce anxiety attacks. Well, there's two reasons for that. One, it's very, very scary. And two, it actually causes release of adrenaline, and that also gives symptoms of anxiety and fear in many individuals. So there's the true effect of the adrenaline, but also the anticipation of all the nastiness the hypo can induce, both immediately but also in the longer term, which is why I think it's such a frightening complication of insulin treatment in type 1 and type 2 diabetes. I hope I've been able to address the questions there. If there's no further questions, I'd like to thank you all very much. I apologize again, sincerely, that I can't be there. But I'm glad that I've managed to stay put on my chair for 1.5 hours, which suggests to me that my problem is hopefully getting better, and I can do my own call tomorrow at the Northern General. Thank you for sharing your experiences. It must be difficult to do so with candor and transparency. And thank you for also highlighting some of the regulatory barriers that people with type 1 diabetes still have to navigate in different services. I hope that next year, Lindsay, I can do this in person. I very much hope to do so. And please do reach out to me for the research that I've discussed if you feel you would benefit. Obviously, it goes without saying there's no compulsion at all to participate. Great. Thank you, Lindsay. Thank you, David.
Thank you.
Thank you very much.
Thank you.
Okay, have a lovely evening and all my very best. Take care. Bye-bye.
Bye.